So it's my pleasure to introduce Mary Naughton. Dr. Naughton has been a medical officer in the Immigrant, Refugee, and Migrant Health Branch of CDC's Division of Global Migration and Quarantine since 2001. She's the sole radiologist at CDC, and she's responsible for quality assessment of panel physicians on site, which involves travel in Asia, Middle East, the Caribbean, Africa, and Latin America. In 2008, she reintroduced on-site training for panel physicians and served as the lead physician for training content for the first 10 panel physician training summits from 2008 to 2013. Dr. Naughton has also participated jointly with USCIS in multiple civil surgeon training activities. She's a native of San Francisco and earned her medical degree at the University of California, San Francisco. She completed her residency at Beth Israel Medical Center in Boston and practiced for 8 years as a board-certified radiologist in Massachusetts, and subsequently earned a Master in Public Health degree from the Harvard School of Public Health before joining the CDC. Dr. Naughton is a member of the Alpha Omega Alpha Honor Medical Society and is a captain in the U.S. Public Health Service. So please join me in welcoming her.
Good morning. It's a pleasure to be here and to see so many people. And earlier when I was saying that we couldn't take questions about other topics, that's because we really want to stay with the topics that we have listed for today. But I'll be showing you an email address where you can send us questions. In the technical instructions at the back, it gives you a fax number to send us questions, and we used to receive questions from civil surgeons by fax, but we have updated and we now have an email address that we can give you that panel physicians also use. So what I'm going to be talking to you about today, just briefly giving you some background, and you also heard some of this from Dr. Chang on TB and TB incidence rates in the world and the U.S., talk about the 2008 TB technical instructions, the 2009 update about using interferon gamma release assays, such as quantiferon and T-spot, that was allowed and is now allowed, pregnancy and radiation, making referrals, and TB classifications. And we hope that at the end of this talk, you'll know that the majority of TB cases in the U.S. are in the foreign-born. You can understand the use of IGRA testing. Know that pregnant applicants must undergo a chest radiograph before the examination is completed. That doesn't mean during pregnancy, but it means before you sign off on the I-693 form. Understand when referrals are required versus recommended, and know how to refer to the TB, we say TI for technical instructions to classify TB. And this goes back a few years, but this just gives you some idea, and you probably have this idea in your own minds about incidence rates in various countries. And you can see that the darker the color, the higher the incidence rate. Our incidence rate in the U.S. now is 3.0 cases per 100,000 population. Unfortunately, that's been our rate for the past 3 years. And it has, it's budged a little bit in the second decimal, but but it hasn't changed, which is one of the reasons why Dr. Shin was talking about needing to address latent TB infection. I think we've brought down our rates largely through addressing active TB, but we need to make more of a push on latent now. And in California, you have a large population that comes over from the Philippines and from Vietnam, and also you have the Mexican population. You can see that the rate isn't very high in Mexico, and right now it's about 18 or 19 cases per 100,000. So even though that's 6 times what our rate is, that's not high compared to the rest of the world, where the rate may be, say, in the Philippines, where we're talking in the 200s, in China, where it's about 90. Or in Vietnam, where the case rate is also higher. And certainly many countries in Africa, although you don't get that many immigrants or refugees from Africa to California, the rates are quite high. So I just put this up to impress that you're definitely seeing people, but you know that from higher incidence countries. And this is the graph for the whole U.S., whereas earlier we looked at the graph for California. And for the whole country, the contribution of the foreign-born is about 66, 67%, as opposed to the 1980s when the contribution was in the low 20s. So it's made quite a change over that amount of time. But for the country, then, it's not as high as it is for California. And in 2015, we actually had an increase in case rates, and I can't show you that yet, or I should say case number, because we don't yet have the graphs for 2015. We have the preliminary information, but it showed that there was an increase in the number of TB cases in the U.S. The overall number went from 9,406 up to 9,563. So it went up by about 150, 160 cases. It did go up in both the foreign-born and in the U.S.-born, but the U.S.-born, the rate remained unchanged, and the foreign-born rate actually decreased slightly. So it's a plus-minus situation. I think the number of cases increased because we have larger populations. But still, the worry is that we haven't had a change in the rate of TB cases in the last 3 years. And this also shows, so the country of birth of foreign-born persons reported with TB in the U.S. And so this shows you the contributions. So Mexico, so 21% of foreign-born cases in the U.S. are from Mexico. And so these are cases diagnosed in the U.S., not diagnosed overseas before people come here. Philippines, 12%. India is usually about 8%. Vietnam, 8%. And these are generally the top 4 countries. And then China's in here in general. Haiti's usually up here. Guatemala isn't always. But you can see that these countries, I think, make up about 45% of foreign-born persons, but about 57% of the TB cases. So, and this is what we were just talking about rates and about overall number of cases. And now to the civil surgeon TIs. The ones that you currently use have been in place since 2008, and looking them up online is as simple as what Rosalind was telling you. The way I look them up is I just Google them. I just put in civil surgeon TB technical instructions or civil surgeon technical instructions, and that will bring you up to the whole page of technical instructions for all of the conditions. And then in November 1st, 2009, we had the update to interferon gamma release assays, because in 2008, we always follow what the Division of TB Elimination says. I'm from the Division of Global Migration and Quarantine, so we have a lot to do with the examination of persons changing status in the U.S. and undergoing examination before they come into the U.S. that the panel physicians do overseas. But the subject matter experts for TB are in the Division of TB Elimination. And in 2008, based on what they were saying, we couldn't recommend doing IGRA testing. In 2009, we could. So, or we could say that you had the ability to use either IGRAs or to use tuberculin skin test. And we gave the option because IGRA was certainly not available in all parts of the United States. It was more available in California. And as I said, the website contains the technical instructions for all parts of the exam, and it contains the updates. And it is important to go online intermittently to see what those updates are. We don't have a system where you would automatically be sent information from us. Your communication comes from USCIS. It doesn't come directly from us. And then, of course, USCIS, as you were told, they have the forms and the instructions. So in going through what the required workup is for pulmonary TB, and this is all in the technical instructions, you can use, what you start with is either the TST or IGRA as the cell-mediated immunity testing. This is for all applicants age 2 and older. You can use it on those less than age 2 if there's, if the person has signs or symptoms. There's other conditions listed in the technical instructions. So that's up to your judgment if you think that the child may have tuberculosis, if they're a contact to a case. If the TST is 5 millimeters or greater, or the IGRA is positive, then a chest x-ray is required. And we do get the question as to, well, why do you choose 5? Why are you not choosing 10? The reason we choose 5 is that if there's an abnormality on the chest x-ray that is suggestive of previous TB, then 5 millimeters is the cutoff that's used to classify the person as having latent TB infection. But you actually wouldn't be doing that. If you had a person where they had the TST that was 5 or greater and they had an abnormal chest x-ray, you need to refer them at that point to the health department because they have an abnormal chest x-ray, and we'll get to that. Sputum smears and cultures are required if the chest radiograph suggests TB, if there are TB signs or symptoms, and I put this in here by error. This is true for overseas. This is not true for here. What is true for here is that you have to do a chest x-ray if you know that the person has HIV infection. And we know overseas that some people do say they are HIV infected because they know that's no longer inadmissible. Other people are still scared that will be inadmissible, and I should say inadmissible medically. It can be inadmissible for reasons of not being able to pay for one's care when one's being evaluated overseas by Department of State. But we do have people who give that history, and then overseas they're required to get the smears and cultures done. Here they're required to get a chest x-ray done, or if they're immunosuppressed for other reasons. Either, they're taking prednisone or another immunosuppressant, or they have a history of organ transplantation, so they're on immunosuppressants. Drug susceptibility testing is required if the culture is positive, so that you know if it's a susceptible case or if it's a drug-resistant case. And this is for the health department to know, actually, and so that they will know what drugs to use. Fortunately, this is routinely done in the United States. So we include this in the technical instructions, but we know that when you refer to the health department, this is what will be done. Overseas, it's the panel physician's responsibility to do all this, and we work very hard on developing labs because this isn't routinely done in many countries. And then, of course, you have to do the proper classification of TB. And this is, when we say classification, we're not talking about the American Thoracic Society classification that goes 0 through 5. We're talking about the A, B, B1, B2 classification that's in the technical instructions, because that's what USCIS needs to see. And then what is required is directly observed therapy throughout treatment for Class A TB. So this is TB disease or TB, active TB disease, some people call it. But usually when we're talking about a spectrum of latent TB here and then active TB here, active TB is when the person, this is what the health department will be deciding, but they're culture positive, their smears may or may not be positive, or they're symptomatic, and in their clinical judgment, even if their smears and cultures are negative, they feel that they need to be treated for TB. This is your part, when you're doing a history and physical examination, as far as TB goes, it's important to get all of this history. Have they been hospitalized? And I found that a lot of people from overseas don't really know if they've had TB or not. And if you probe, you may find out that, yeah, when they were a child, they had something in their chest for a while and they're not sure, you know, they may or may not have been treated, or if they were treated, their family members may or may not remember what drugs were given. But sometimes you'll come up with a history that, you know, yes, they were treated for a long time. Sometimes we find overseas that history doesn't come out until the person is shown the chest X-ray, and then there's more history. But if, you know, we realize you can't always get a hold of everything, but certainly if somebody's been treated in the U.S., it's important to get that record for the applicant to bring it to you so that you know what's been done. Review of systems. Of course, if there's a cough that lasts 2 or 3 weeks, hemoptysis, fever, night sweats, weight loss. But remember, you're doing active screening. It's very unusual to do active screening for TB. Now, overseas, a lot of people don't give any symptoms for TB. And they may later give some symptoms after their chest X-ray is abnormal. They may feel they can't tell the truth because it's too important to get into the U.S., or maybe too important for their children to get into the U.S. But it's important to, again, to keep probing. And also to realize that some people actually really aren't going to notice that they have symptoms because you're doing active screening and it's too early for them to notice that they have symptoms. So the fact that someone says they're asymptomatic doesn't really give you any information about whether or not you should continue with the workup. And that's one of the things that's a bit old in our technical instructions that we need to change, but I think most health departments are aware of that. On the physical exam, you know, certainly listen well to the chest, check the lymph nodes, and certainly on kids, you're checking for hepatomegaly, splenomegaly, for neck stiffness. And, you know, remember to, you know, actually palpate, hit somebody's spine, check their extremities. Most people who have extrapulmonary TB also have pulmonary TB. And so it's important to do a thorough exam. And then here's just to remind you about the tuberculin skin test. So this is done for everybody 2 and older, sometimes if they're less than 2. The only technique you can use for the civil surgeon exam is the MAN-2 technique. You can't use the multiple puncture devices because they don't give a reliable amount of PPD. And it really has to be somebody who's trained in doing this. How many actually still do tuberculin skin testing versus IGRA? Okay, so a fair number of you do. Now, how many offer both to change of status patients or adjustment of status patients? Okay, and for this, it actually takes more skill than you would think. I mean, when I get tested once a year, and we still use the tuberculin skin test, and I've had people give it to me who actually didn't know what they were doing, but they were okay if they didn't get a wheal that was 5 to 10 millimeters. This was when I wasn't getting it done at CDC. And so I had to say, no, that isn't okay. You're going to have to give me another injection. You know, you can go a couple inches away, do it in the same arm, you can do it in the other arm. But if somebody doesn't get a wheal, and I usually feel if they don't get, you know, if you don't get, if it doesn't hurt a little bit, it doesn't hurt the applicant, it's probably not a good injection. It needs to just be a little uncomfortable. That's one of the things to be tested because some people just don't inject high enough in the dermis. They're not superficial enough. And it is an intradermal injection. It's not a sub-Q injection. And then reading isn't as easy as I would think. Can we have the lights down a little bit? Is that possible to put them down in front? Because here on this, you can see that, and here is the induration. It's a little hard to see here probably for you. Here's the erythema, but it's just the induration that's measured. And so somebody's put little pen marks, thank you, here and here so that the induration can be measured. And they need a flexible ruler to do it, and it's measured transversely. And I know some places still measure longitudinally and transversely, but it's just the transverse measurement that counts. And here's some instructions here on this particular box that's from the Southeastern National TB Center. And absolutely no self-reading. That the person has to come back. Luckily, for the type of exam that you're doing on applicants, they're motivated to come back because they're motivated to adjust their status. And then perform the chest X-ray if the induration is 5 millimeters or greater. Okay. IGRA, of course, is a blood test. It measures a component of cell-mediated immunity to Mycobacterium tuberculosis in fresh whole blood. It's much more specific than doing a tuberculin skin test, which uses, quote, purified protein derivative, but it's not purified. And to the extent, or I should say, because it has many different antigens in it. So it's nowhere near as specific as doing an IGRA. And these are the types, as we mentioned before. If the IGRA is positive, do the chest X-ray. These are the instances in which you wouldn't have to do an IGRA or a TST if there's written documentation signed by a healthcare provider that the TST in the past has been 5 millimeters or greater, and that looks like a legitimate documentation to you, then you don't need to repeat it. We included if there's an oral history of severe reaction with blistering to prior TST, you don't need to do it. And we realize that might be a slippery slope by saying you just need an oral history, but the consequences of doing a TST when somebody's previously had a severe reaction can be very severe. So we wouldn't want you to do that. Or if you're doing an IGRA documentation of a prior positive IGRA, but it has to be the most recent result, signed also by a healthcare provider. And exactly what's needed on these documents is included in the 2009 update. And I'll show you later, but when you go on the page that has the technical instructions, there's a menu on the left side, and down the bottom is the section that says updates. So that's where you would find that. So in the above circumstances, you perform the chest X-ray next. What CDC says, and this is the Division of TB Elimination, is don't perform another type of cell-mediated immunity test to achieve a negative result. So you've got the result, you need to go on from there and do the chest X-ray. And we still don't have all the information that we need for IGRA testing as far as seeing how many people in 10 years, 20 years do develop tuberculosis disease. So even though many people favor IGRA, you have to realize we don't have all the information that we need. And as I say, we go by what the Division of TB Elimination says. I expect that they'll be updating their information in the next couple of years, and when they do that, we'll update our information. And so you've seen this. So this is Form I-693, and again, this is just telling you in Part 5.1 here, the tuberculosis part, that you have to do either the skin test or you have to do the IGRA test. And you can say that it was not administered because of one of the 3 exceptions that were on the previous slide, but in the remarks say what it was and that you saw documentation of it. If it's a TST, we want the date applied, when it was read, the size of the reaction. And this tells you right here, it's negative if it's 4 millimeters or less of induration, and that if it's 5 or greater, a chest X-ray is required. And one of the nice things about Form I-693 is that it serves as a teaching tool, too. So if you're thinking, well, I'm going to have to look this up in the technical instructions, you actually don't, because it's right here. For the IGRAs, you can say if there was an IGRA exception. If it's given, you just say quantiferon or T-spot when the sample was drawn. And then what we say, and this is because it's active screening, is that if it's an indeterminate or borderline or / equivocal result, we don't require a chest X-ray. And we've talked this over on more than one occasion with Division of TB Elimination. Because if you had somebody come to you who was symptomatic and you had a high suspicion, that they had TB, you would say if it was borderline, you need to repeat that. You need to do something else to see what's going on. What we say is that if you're suspicious that they have TB, you need to go ahead and get a chest x-ray. So you don't need to repeat, just get the chest x-ray. Because you're dealing with populations, not everybody, but many people from overseas come from high-burden TB countries. So with, as far as prior BC vaccination, and this has already come up, it doesn't change the testing requirement or the actions based on the test results. And we know that IGRA will not be falsely positive when there's been prior BCG. We know that it can be, we know that TST can be when there's been prior BCG, but not everybody who's been given BCG is going to have a positive tuberculin skin test, especially if it was given years before. And so you're required to go ahead and do the chest x-ray. And as was mentioned by Dr. Chang, if somebody was given BCG, it is often because they live in a country where the TB rate is high. And so you want to continue with that high suspicion and go ahead and get the chest x-ray if the TST is 5 millimeters or greater. And as I was just saying, it's just in this screening population that you're doing as a civil surgeon exam is where you would say that indeterminate or equivocal results are considered negative, but if also the person has TB signs or symptoms, you have to go on and do the chest x-ray. Does that make sense to you? Okay. Or is immunosuppressed chest x-rays required? And we know that's because TST can be negative when someone is immunosuppressed. Chest x-ray, I don't know how many of you might recognize this person up here. He was one of the Three Stooges from my childhood, but I couldn't watch them enough to be sure who this is. Some of you may know if this is Curly or Mo or whomever. Okay. But this gives you an idea. Actually, it gives you an idea that you don't want to take an x-ray of the whole body. They include a bit too much up here, but you want something that's taken of the chest. And again, this is who it's required for, 5 millimeters or greater, or TB signs or symptoms, or known immunosuppression. So pregnancy and radiation, this comes up as a topic quite frequently. And what we say is that the chest x-ray is required before the exam can be completed. So it can be performed before or after, or during or after pregnancy. And the reason we require this is because of the caretaker transmission to the child. There is the intrauterine transmission. We're not as concerned about that because what's more common is for a caretaker to transmit TB as they're leaning over and breathing on a child as they're changing diapers and dressing them. And so we want to know if the mother is at risk. The safety of the fetus must be considered, but you have to realize how low the dose of radiation is. Now, for TB, usually we take just the frontal view. So, and for an adult standing up, that's the beam goes through the back of the chest and out through the front of the chest and onto the receptor. And the dose is 0.02 millisieverts, but the best way to remember it is that's less than a round trip that should say coast-to-coast flight. So I don't go quite coast to coast, so I'm probably getting the 0.02 millisieverts for coming out here and flying back to Atlanta. But that's the amount of radiation. It isn't enough radiation when the woman is double shielded. So what we require and what should be done routinely in the U.S. is a double wraparound lead shield that covers the abdomen and the pelvis. And the beam is not directed towards the abdomen or the pelvis, it's directed towards the chest. If it's collimated enough, so that means if it's just directed on the chest structures, then all you get is scatter radiation down towards the abdomen and pelvis. Most of that has to try to get through that lead. And so there's just a minimal amount that can even penetrate near the fetus. It is not enough to cause a miscarriage. It's not enough to cause fetal death, all these things that you hear about. What radiation at medical doses can cause later is childhood cancer. But again, we're talking about larger doses for the most part. You can't say, oh, 100% that would never happen. But in general, we're talking about much larger doses. So what the American College of Radiology says is that generally the risk of childhood cancer after a chest X-ray is the same for any child whose mother was not radiated during pregnancy. Well, if there's any radiation, it would be the whole child. So I haven't, it wouldn't be specific to thyroid or specific to another area. And I don't even know how much work has been done on that because the main message is it wouldn't be a higher risk than for a child whose mother wasn't radiated. And this just goes into some details about, the applicant must be advised. And I realize in general you wouldn't be doing this. This would be done at the hospital or clinic where the radiation or where the chest X-ray is done. How many of you have chest X-rays in your own clinics? Okay, so this part then, if you're the person who's responsible, then this part does apply to you. How many of you read your own chest X-rays? And do you also have them read by a radiologist or a chest physician? So, and that's what, now overseas we require that they be read by a radiologist. And those technical instructions are a little newer than these. These were written a few years before 2008. And that's, a lot of that is to catch subtle findings that might actually pick up something else other than TB. But it's just always important to remember that you have to read the whole image. So, and this is what this says. This is what we require for civil surgeons. The chest X-ray should be interpreted by a radiologist or other qualified physicians who's trained and experienced in reading chest radiographs demonstrating TB or other diseases of the lung. On this image, what side would you say is abnormal? Okay, so we have a left, we have a couple rights. So for those of you who think it's right, is it lower, mid, or upper lung? Okay, it's the apex. And so it's right there. And this is smear negative, culture positive TB. And this was actually taken at one of the panel sites. And if you don't follow that rule about is it as dark here as it is here, then you can blow by things that are more subtle. And remember that since you're doing active screening, you have to expect that there's going to be more subtle examples or findings of TB on chest X-ray. Don't be expecting to see the big cavities. Yes? Yes, it is. Yeah. Okay. But what we say is that if the chest X-ray is suggestive of active or inactive TB, or the applicant has TB signs or symptoms, they must be referred to the TB control program at the health department. So this partly helps you because it takes some of these decisions that could be very complicated out of your hands. The reasons that we say this are that TB is a significant public health problem. TB patients are uncommon in private practice. How many of you have diagnosed or have an applicant who was diagnosed with TB? Okay, so some of you have. But the diagnosis and treatment issues have increased in complexity. For directly observed therapy that is needed, you really need to have a team that does that. And so you need, and that's what needs to be done to ensure that people take the medication they should. Some people think that, if you have a patient who's well educated or they're well motivated, they're going to be taking their medication every day. Certainly, if somebody's well educated, it does not mean they're going to take the medication as they should. So And I have seen cases when I've been asked to review them, which we are asked to review at times for different reasons by USCIS, and that it's very difficult to make it happen if the person isn't treated through the health department. And the health department also conducts the contact investigations and source investigations. And source investigations would be for children because it's going to be an adult who gave that child TB, except in very unusual circumstances. So again, this is some more of the form. And again, this is instructing you. You know, the chest x-ray was not required, so that means the TST was 4 millimeters or less. The person wasn't immunosuppressed. They didn't have TB signs or symptoms. The chest x-ray is required due to the TST or IGRA, due to TB signs or symptoms or immunosuppression, or because of one of the exceptions where you go straight to chest x-ray. And then here's the chest x-ray when it was taken, when it was read, and results. This is all we have for results. And of course, as a radiologist, I'd like to see a lot more. But what isn't said here is this is where you need to make the referral to the health department if the chest x-ray is abnormal. And the health department is going to have to do its part before you know how to do the classification. So that will be your responsibility to do the classification, but they're going to have to give you the information so that you can do it. So required referral, chest x-ray suggestive of TB disease. There's a glossary in the back of the technical instructions that talks about active versus inactive. Now, what we've really learned since we put out these technical instructions is that you can't say that anything that suggests TB is inactive. So if you're even seeing something like a few nodules that, well, there's a few things that are inactive. Calcified nodules, and that's all you see, you don't need to refer that to the health department. If there's just calcified lymph nodes, you don't need to refer that to the health department. But if you see just what looks like a linear scar, what most people would call a scar, I mean, we know from looking at chest x-rays that we're not pathologists. We can't say if it's a scar. So that needs to be referred. Are there subtle signs of volume loss, too, that may be hard to see? But everything that could suggest TB needs to be referred to the health department. And you need to use the referral portion of Part 5 that's on Form I-693, and then you await the response from the health department. Then they go on and they fill out their part of the form. So this is for required referrals. What we say about latent TB is that you don't use the referral form because this is a recommended referral. And when we wrote these technical instructions, there were a couple reasons that we said recommended instead of required. One is that the inadmissible conditions that USCIS was telling you about, Bruce and Rosalind, say active TB. So it's not, a person is not considered inadmissible to the U.S. if they have latent TB, and you're doing this medical exam for inadmissible conditions. The other thing is that Division of TB Elimination made clear to us that there are lots of health departments in the U.S. who wouldn't be able to handle all of the referrals for latent TB infection. What we say in the technical instructions is that you need to be in conversation with your health department to find out what referrals they can treat for latent TB infection. And we actually say that in 3 different places. And that's something that you need to do proactively before you have somebody even. And I'm sure you see lots of people who qualify as latent TB infection, so that you know who you can refer to them. And can they treat people who qualify because they've only been in the U.S. less than 5 years, they come from a country that has a high incidence of TB, and they have a TST that's 10 millimeters or more. So that's the cutoff for the definition of one of the, or most common, I think you would see, definitions for latent TB infection. So that cutoff is 10, not 5. And this goes through You have this as a handout, and it's on one side of that piece of paper that you got because we thought it'd be hard for you to see. But this is an algorithm that takes you through what you need to do as far as making what tests need to be done and what referrals need to be done. And so, you know, here, radiographic or other findings suggestive of, whoops, here we go, signs or symptoms of TB, regardless of chest radiographic findings, and this is the chest radiograph suggestive of TB. So it's required to refer to the health department. And then what the health department does is that they make a decision. You know, they go through the history, they talk to a person some more. Are sputum smears and cultures required or indicated or not? And for you, if they don't do smears and cultures, then the person is class B2, pulmonary TB. They may not do that because the person may eventually have produced a chest x-ray, it's unchanged, they have no signs or symptoms. I know that a health department that I work at in Georgia, they're very conservative, and I think they should be. And they do many smears and cultures, not on one person, but they do a set for minor findings because they know that they can be fooled. And certainly what I learned when I was in training doesn't apply. You know, we used to say, oh, looks like inactive TB. Well, that doesn't mean, if there's a lot of scarring on a chest x-ray, that does not mean there isn't active TB also. So that requires a referral for smears and cultures. So I won't go all through this, but this is important, and you can just click on this. If you go to the index and the technical instructions, you can just click on the different chapters, and this is at the very bottom, and it's figure 1, as I recall. So these are the TB classifications. You know, class A is active. B1 means that smears and cultures were done but were negative. 2 means that they weren't done. The health department felt they weren't necessary. B means it's latent TB. Then there is B, latent TB infection. And then there's class B other, which means that the chest x-ray was abnormal in some way, say the heart was enlarged, but it's a non-TB condition. And you only mark these classifications if the chest x-ray is obtained, because you can see they all indicate that there's some sort of abnormality. Now, this is even harder to see. This is on the other side of your paper. But this tells you what exactly to do also. Here are the criteria, and this is what you really want to look at. This tells you the classification. This tells you, do you refer to the health department? And if you do, is it required or is it recommended? So down here is latent TB. And this makes the point that there are different definitions for latent TB infection. You know, for recent arrivals to the U.S. And less than 5 years, it's 10 millimeters or greater. 10 millimeters or greater also applies if you have somebody who's been in the U.S. for 15 or 20 years and they're diabetic and they have a clear chest x-ray, but they have a TST that's 10 or greater, then that's another, that they fit that definition of latent TB infection. And if your health department can take those referrals, refer them. If it's a young child, less than 4 years old, I think now it said less than 5, refer them. And then you get to the less than 5 or greater, and then we're talking about people who you know are immunosuppressed. You've got other people, recent people you know who are contacts. They fit that definition, and you should also refer them if you work with the health department that can take the referrals. And of course, this means that their chest x-ray is normal, not abnormal, or it only shows calcified nodules or calcified lymph nodes. And this just gives you a little better idea of what this says. So no evidence of active TB disease. And if you look in the text, we have a whole page that goes through the criteria for the other LTBI categories. So we can go, I think, just, we've really already gone through this. So Class A, abnormal chest X-ray, required referral. And then after the treatment's finished, I would think that's when you get the form returned to you from the health department, and then you can sign the I-693 form, because that person is inadmissible until their treatment is finished. That's if they have active TB disease. We just talked about B1. If they have smears and cultures done and they're negative, they're admissible. B2, where they don't have the smears and cultures done, but the health department feels they don't have active TB, they're admissible. So latent TB infection, these are some of the different categories we were going over. If, again, you don't use the form, and you can sign off on the form. If you refer them for treatment, even actually if you don't refer them for treatment, we prefer you try to do everything you can to refer them for treatment. They still are admissible. And again, we had to do this for those reasons that the inadmissible condition is active TB, and there was concern that there wouldn't be enough capacity to treat. These are the other LTBI criteria, which are in the technical instructions. Okay. And when you mark no Class A or Class B TB, that would be for someone, the TST is less than 10 millimeters, the chest X-ray is abnormal. They have no TB signs or symptoms, and they don't meet any of the criteria for latent TB at the 5 millimeter cutoff. If they do meet those criteria, then they would be marked as latent TB. If they don't, then, if it's not a young child, if it's not other criteria for the 5 millimeter cutoff, then, and their TST was 7 millimeters, they had the chest X-ray done and it was normal, that's a no class. And we talked about Class A, they're inadmissible, they have to finish their treatment. And let's see, if somebody does have known HIV infection, you would mark them as, it would depend, I would think the health department, well actually for them, this is different than overseas. You would mark them as B other for HIV infection is what it comes down to. So you have to mark that in addition to a TB classification. And this I just wanted to show you as far as references or resources go. So this is what you'll see when you Google for technical instructions for civil surgeons or TB technical instructions for civil surgeons. These are the actual links. And this is the HIV guidance. And I know this has already come up as a question, but since January 2010, there has not been required testing for HIV. This is very important. This is the email address that you can reach us at. So it's cdcqap@cdc.gov. So everything at CDC is at cdc.gov, and QAP is for Quality Assessment Program. So cdcqap@cdc.gov. We answer the questions about the technical instructions. We can't answer form questions unless it has to do with a medical question, and we can't answer those questions about becoming a civil surgeon. And so there's the email address again, and I'll show it to you again this afternoon. And we're going to have a short break. I think I'm at the end of my time, so if you have any questions, I can take those questions during the break. And then we'll also be here over lunch, so we'll be available for questions. And then this afternoon, I'll be talking about vaccinations. So.
Quick reminder to please turn in those purple sheets, the pre-test, to the back table.
Thank you.